So we thought we'd have a kind of lightweight, inconsequential conversation with somebody who didn't matter very much.
So I'm going to be chatting to Roy. Just because we need to go on.
I know I shouldn't have done that. Okay. I'm in for a tough time tonight, I think. Anyway, it's great to see you all. Who was here last time we had a chat with Simon? Put your hand up. Oh, only one or two of you. Okay, fine. Well, that gives us a bit of a steer on what we're going to do. If you just joined us on Periscope, good evening. Welcome to the King's Fund, the overpriced King's Fund. It's lovely to see you, and welcome to our guests. First of all, it would be great, I think, if we could have our traditional message from our sponsor. Ladies and gentlemen, give it up. He's here. I can't believe it. It's the fabulous, unbelievable. It's Michael Thick.
It's quite difficult to get a microsecond on Roy's stage, isn't it? But thank you anyway.
Thank you, that's enough. That's all we have time for.
See, give him a millimetre, he'll take a mile. A great welcome to everybody. Thank you very much for coming. It's our pleasure to sponsor it, as always, with such a wonderful guest also. And I'm sure you'll have a wonderful evening.
Thank you very much. Good. There's nothing like a good introduction, and that was nothing like a good introduction. Thank you.
Oh, change that tape, please.
And Patrick is here. Stand up, Patrick. We just say a big thank you to Patrick. Also to the unsung heroes who are outside. What?
We've got Jan here as well.
Yeah, I know. I'm going to let you do that later on. Yeah. The unsung heroes outside from Salix, who managed our front of house since we were starting out, and we're very grateful to them. And of course, to our special guest, Simon Stevens. Now we thought we have a new gimmick this time, right? We're going to make it a bit different. We've got the steady hand test, Simon. Okay. Yeah. So this is a new test that NHS England, I think, are going to be employing for all managers. We thought we'd start with you.
Sure.
Okay, would you like to start?
Yeah, absolutely.
Oh, hang on a minute. Yeah. Well, I'll tell you what. Christ, hang on. I'll do it first, okay? And I'll show you how to do it. Okay.
Yeah.
Okay. Fine. So it's pretty easy.
Yeah.
Okay. And now I'll turn it on. You can have it.
Sure. Yep. I got it. Actually, Roy, it looks like the sort of thing that might be installed in a Texas penitentiary if the going gets rough.
Right. Yes.
Let's draw available.
Well, okay. Right. Anyway, so you can all have a go at that later on. Well, Simon, thank you very much for coming.
And that concludes this evening's entertainment.
Yes, thank you very much. Can we all get to the bar and do some much more important stuff? Thank you for coming. I know you've had a busy day. You've been busy with cancer today, have you?
Yes. In fact, little noticed on Friday, we saw the cancer outcomes statistics for England. And so there was a big meeting today called Britain Against Cancer. And what the figures on Friday showed is that over the last year, cancer care in the NHS in England has got better, such that 2,400 families are going to have loved ones who are going to be with them this Christmas who would not have been around last Christmas. So that's what a 0.8% increase in the 1-year survival rate for all cancers means when you've got 300,000 people getting a new cancer diagnosis. So we obviously have a big debate about all sorts of things in the NHS, but what we tend to forget is that on most of the big killers and disablers, actually the quality of care is getting better, and that is clearly evident in cancer. But what I was also doing was some very tangible action to upgrade the radiotherapy equipment on offer in hospitals across the country. Last time we had a big upgrade was about 15 years ago.
So I just said we're getting some comments. The volume isn't great, so I don't know if it's the microphones or whether you might be able to speak up a little bit.
Is it on?
I might have disconnected myself at that point.
Yes, I can think of no finer thing. Right, is that any better?
Well, let's see. I'm sure Periscope will tell us. We haven't
Yes,
quite got it right.
Speak.
Right.
Well, so the point I was really making is that about 15 years ago, on the back of lottery funding, we had a big replacement
Didn't
program
Alan
for-
Milburn put a lot of stuff in as well?
Yeah,
you
so
remember
with
that?
cancer,
and then we had no staff to operate it.
No, we did. And a lot of what happens with cancer is that we focus on the new cancer drugs, but actually it's actually surgery and radiotherapy, which makes a big difference to cancer survival and treatment success. So anyway, we're now kicking off the biggest upgrade in radiotherapy we've had for 15 years, and the first 15 hospitals are getting their new radiotherapy machines in the next 4 months, which is pretty darn good.
It is good. I've never really understood the cancer stuff because on one level we're supposed to be very good at cancer, on another level we're not. But if you actually look at the data, it's collected by Eurostat, and Germany, for example, don't count all their data. In France, it's done on a different basis. Outcomes are measured. I mean, the Eurostat data upon which we are compared isn't great, is it?
No, I think it shows that we've still got lots of opportunity to improve cancer outcomes in this country, and in fact there's still a big variation between different parts of the country. The good news is that variation has fallen by about a quarter since 1999. So the parts of the country that were doing worst on their cancer outcomes 15 years ago are catching up faster, and so we've been narrowing the gap as well as improving cancer outcomes overall.
And what is it with early presentation? It seems the big issue around cancer is the earlier you get diagnosed, the better it is. And is it because the GPs don't recognise the cancer as often as they should? Is it because we don't go to the GP as often? Is it about access to the GP? It seems to be a whole story, particularly around blue-collar male workers, where the outcomes are poorer.
Yes, and also for some black and minority ethnic patients, services are not accessible, or people are not presenting soon enough. So the big cancers where this is a real issue are lung cancer and colorectal cancer. And we've got far too many patients who are getting diagnosed when they're so far advanced in their illness that actually the ability to really produce a big benefit from treatment is much diminished. And the paradox with bowel cancer is that if you are diagnosed right early on at stage 1, then 9 out of 10 patients are alive 10 years later. If you're diagnosed at stage 4, then 9 out of 10 patients, unfortunately,
But it's
are dying.
so horrible, isn't it? I mean, to get, you've got to start fishing around the Kazi with a spoon to do the sample, and it's just Neanderthal. There must be a better test.
Is that what the Neanderthals did?
They probably didn't have a Kazi. They fished around the pile. But I mean,
We've got good news on that front, Roy, actually, on the fishing around in the Kazi front. Which,
you heard it here first.
Exactly. And that is the reason that you have to do what you just described. Is up until now we've been using a screening test called FOB, fecal occult blood test, that actually requires 6 scoops and you to keep it in the fridge.
Do you put it above the cooked meats or below?
Yes. However, there's a
Where's Duncan Selby when you need it?
There's a new bowel cancer screening test called FIT that actually only requires 1 scoop.
Fart, is it?
And 1 scoop. And,
what an improvement!
yeah,
One
and
scoop.
we're not talking ice cream here.
Yeah.
And the point is that that's likely to improve uptake.
Isn't there a blood test for this or something else?
Well, no, this is actually going to make a big difference, and then as that's rolled out, it will also mean that more people will come forward for.
You still
screening,
fish around in the
signal
Kazi.
adoption. No, I think this has been shown to make a big improvement to the uptake. At the moment, only about half the people complete the 6 scoop screening. And the 1 scoop.
What are we doing? All the things
I know you started it. I mean, I was talking about radiotherapy machines.
Yeah, the blondie is a colorectal
Colorectal nurse.
nurse.
This is brilliant.
Yeah.
Loving it.
She works where the sun don't shine all the time.
Yes, with
fantastic.
Monsieur Lilley.
Yeah, that's why I get on. Yeah, I manage him so well because he's you got it.
Do you know that tonight's not going so well? Yeah. Okay, well, I'm sorry I asked you what kind of a day you had, really. Tell us about your beard, for God's sake. What's that all about?
Well, it's laziness, basically. I mean, I went on holiday in August to...
Tell them where you went.
Well, I went to the North Pole, as you do, on a Russian nuclear icebreaker.
Just to get away from the Daily Mail.
And, so this was a couple of weeks, and I kind of just let it all run to seed during that period. And so my wife kind of, said, "Oh, it's all right for now," and then the kids sort of said, "Keep it for a bit." So kind of each weekend, I think, okay, it's time to go. But as my son pointed out to me, it's kind of proof positive that we are way past peak hipster if I've got a beard. Thanks for that, son.
Your son sounds very cool. Look, there'll be a lot of people in the audience who haven't heard you speak before.
That's why they're here. If they had it on, they wouldn't be here tonight. Is that what you're about to say?
No, at the last health chat, and I don't want to visit some of the old ground, but I do think you do have an interesting background, which I won't spend a great deal of time on because some people will have heard it before, but a lot haven't, and I think it does position you in an entirely different light, because actually you come from up north, although you don't sound as though you do anymore. You were a Labour councillor as well, I think, which a lot of people will be surprised to know. And
yes, I was born in Birmingham, and in fact was in Birmingham last week, and part of the conversation I was having with folks at the NHS Providers Conference was just looking at the fact that not just the country, but even cities like Birmingham are cities divided, and there's a 10-year life expectancy difference between different wards across the city of Birmingham, and it so happens that the part of East Birmingham, Shard End, where I was born, is the bottom, is the worst for life expectancy, and male life expectancy in Shard End has actually been going down the last several years, whereas for Birmingham as a whole, and indeed for the country as a whole, it's been going up. So I think it's kind of good that we stay focused on some of these inequalities that are not being cracked. But then, sort of fast forward, yes, I was for a few years, 4 years, a councillor in Brixton, and that's obviously a different experience. But I think I'm probably the only person doing my job from the NHS point of view who has also sort of previously been on the local government side of the fence. So I kind of see it from both angles in a way.
have you given up political ambition?
Sure.
Or would you turn back to that?
No, I didn't. I never had political ambition. I mean, I signed on for the NHS. Back in 28 years ago, and then sort of done various healthcare-related jobs, and that's been what I.
Because you had a very interesting job at Number 10, didn't you, Tony Blair's?
Yeah, I spent 7 years at Number 10 of the Department of Health in the late 90s and first half of the 2000s, but interspersed that with kind of jobbing healthcare management jobs around the NHS, the States, Brazil, China, other places.
Yeah. It's an interesting back catalogue. Right, well, let's get up to date, really. I mean, I suppose the big topic is the 200-week forward view.
Yeah.
How's it going?
Well, we're in year one of the spending review, and I think 2016-17, although there are kind of huge pressures right across the NHS, entirely predictable given a growing population, an ageing population, all the financial constraints we're facing. Actually, 2016-17, this year, is going to be a year when I think we're going to make quite a lot of progress relative to where we were last year. I mean, even on the sort of basic question of deficits in hospital trusts, I think we're on track to have cut hospital deficits by more than 2/3. I think we will have made some clear initial steps on helping GPs and trying to reverse the issues that have arisen in mental health services as a poor relation over many, many years. And I think that alongside that, the process we've been using locally to try and ensure that people are thinking beyond their own individual organisation, but a shared point of view as to how their health system should develop, the STP process. I think, that's not perfect, but it's moved the conversation along and strengthened relationships, which were otherwise somewhat under pressure.
Yeah, I kind of get that, but of course they've had a bad start, haven't they, really? Because I think people got the wrong end of the stick about what they were doing. There was a whole load of accusations, not least from Chris here, who was talking about STPs in secret planning and all the rest of it. They kind of, the communications bit got off to a bad start, don't you think?
I think there's a circle to be squared here. 40 out of 44 STPs have now been published, and the remaining 4 will be published by the end of next week. And the truth is that in most of the country, that has kind of happened without the mushroom cloud going up. So I think it's not unreasonable that people have a chance to kind of debate through proposals before they set hairs running in public. But what's quite clear is we're now at the point where we've got to turn the proposals into concrete plans, and in order to do that, we've got to have much greater engagement and discussion with frontline nurses, therapists, docs, and local communities, and that's what the next several months will be about.
I mean, you know yourself as a counsellor, as a former counsellor, certainly I did, that the consultation process could kill this off, really, I think. It's easy, I think, for communities to delay real substantial change, and some of the STPs are substantial change. I'm not saying it shouldn't be, but it's still a substantial change. So, it's simple enough, really, to stall the consultation process, and you end up with all the judicial review and all that. I mean, finding a way through that, it seems to me, is now the next big job.
Yes, although I would say that actually the sort of content, the sort of active ingredients in most of these local proposals is not, for the most part, the controversial stuff around, where will the maternity service be located, or what are we doing with the A&E department. Actually, what most people are working on is how do they help GPs come together to create, urgent care hubs, other services that would relieve some of the pressure otherwise flowing into hospital. They're pretty clear they've got the memo, the message that we can't keep raiding mental health services to bail out other parts of the system. So they're, I think, pretty clear about needing to change that. And there's also a kind of bigger debate around some of the way the workforce is deployed. None of those things are the sort of classics of public consultation on hospital reconfiguration. But are there some of those? Sure there are. Some of them, I think, are long overdue. There's a public consultation just been launched within the last several days down in Dorset, for example, which is proposing bringing together Bournemouth and Poole hospitals. And for those of you with not that long memories, you'll recall that 2 or 3 years ago, that very idea was blocked on the grounds that it would reduce the competition between the two hospitals that are 8 miles apart. So I think the fact that we're now able to kind of get a bit more kind of partnership and planning back into the system, and they'll have that dialogue with the folks around South Dorset, and I think there's a good chance they're going to be able to pull that off.
2% of the overall savings are supposed to be coming up from reduction in demand, and Duncan Selby's rattled a few bars by saying that the public health agenda has been neglected by a lot of the STPs. Where do you think we're going to go with that? Because actually, I think that's a good thing, because it binds the local authorities much more into this, doesn't it? We have some of the areas, it seems to me, we have approached it in a very in just a clinical model rather than the whole engagement across the communities. Well, I do think local government, although often the health is a bit sniffy about local government, but I mean, I do think local government does have a big role to play in this.
It does. Obviously, local government's under pressure, given the sort of budgets that they've got at their disposal, and there are things that local government can do that aren't about funding services, but are about using their broader either regulatory powers or ability to kind of mobilise change across a geography. There are things that national government needs to do, and I personally thought it was pleasing to see government holding its nerve yesterday on the sugar tax proposals on sugary drinks, given the impact we know they're having on childhood obesity. And then there are kind of other broader changes that you sort of don't notice kind of year by year, but actually the compound effect of which is far more profound than a lot of what we spend all our time talking about. So the fact that 1 million fewer adults are smoking than 5 years ago, I mean, that is huge. I mean, 8 million down to 7 million, that is going to have a profound impact on future improvements in cardiovascular disease and cancer rates, and it's part of the reason why over the last 10 years we've had a 44% reduction in the premature death rate from cardiovascular disease, which is incredible, actually. I mean, think about that, 44% fewer heart attacks and strokes for people aged under 75. If that hadn't happened, then, I mean, just think how jam-packed our A&Es would be, and they already are.
Yes. They are.
They are.
What are you doing about it?
Well, I think there are 5 sets of things that we believe, based on what people say appears to work in different parts of the health service, that need to get sorted out. One of them is around changes to the way the 111 service works. We've got about 14 million calls to that each year. We want to have a higher proportion of those calls that are actually getting to talk to a nurse or a paramedic or a doctor rather than a call handler. That's been shown to then provide more expert advice and fewer people getting referred to hospital. Secondly, well,
bit of common sense.
you asked. Secondly, there are changes that are being tested in ambulance services around the country to give ambulance services more ability to an extra 120 seconds to figure out what sort of ambulance response is required, because what's been happening is if you have a very short period of time to do that, then multiple ambulances are dispatched, and a lot of them then get turned away en route because they find out they're not needed or they're diverted from another more urgent job. So it's not a sensible way of... So there are various other changes in the ambulance service that will be part of this. Then there are changes at the front door of A&E departments, so that you've actually got what's called streaming, so that you figure out if somebody needs effectively a primary care service there and then, GP service, they're not sort of feeding straight through into the kind of, you know, the A bit and the E bit of the hospital. It's not actually an accident, it's not an emergency, but it's something we can do there and then. Fourthly, there are flow issues through the hospital, and that is around things like whether patients are being reviewed on a timely basis, whether they're having their medications written up the night before they're likely to be discharged, the proportion of patients who are available to be discharged home before midday, because otherwise we've got too many hospitals that basically operate like a hotel where the guests for tomorrow check in before the guests for yesterday check out, and that's kind of what we mean when we talk about flow. And then the last piece is at the back end, we've obviously got lots of kind of delays when people are ready to be looked after back home or in some form of social care, ensuring that that works smoothly, and there are all sorts of practical things that we know on that. So it's a long answer, but the answer is, Roy, if we do those 5 things, then it's going to certainly put us in a much better position.
I mean, from our travels around the country with the Academy of fabulous stuff, there's a shed load of really good stuff going on, and it's not all silver bullet, it's silver buckshot stuff, and some of it's quite small really, but it aggregates to making a big difference.
Yeah.
You know, we see it all the time at the East conference that we were at today. Again, you know, there's some really good stuff going on, but we're still left, I think, with the big problem, and that's getting people home. I mean, we've seen some great stuff on discharge to assess. Yep. Which, when I first saw it, I thought, you're having a laugh. This, you know, Granny's going to get marooned and no one's going to do anything. But I think Nottingham pioneered it, and was it?
Aintree.
It was Aintree.
Aintree did it. Well,
Aintree did it
Yeah, South Warwickshire has done it.
Well, they copied it. I mean, it was one of the most popular things we had on the Academy. And a shed load of people have copied it and been to see them. But it does, of course, mean getting social care ducks in a row. I mean, it was disappointing, wasn't it, that there was no more money for social care in the autumn review?
Well, as you know, I certainly have said that if more money becomes available, then I think there's a very strong case for social care being front of the queue, and you know, I think that's not given up on the idea that that's what will come about.
Do you think that the Chancellor will come back with more money? Do you think?
As I said, I've not given up on the idea that this case will be heard.
Well, I mean, it has to be, doesn't it? We can't carry on with social care the way it is. They've had their budgets cut to ribbons, haven't they? And now we're seeing, of course, it's not perhaps in your bailiwick, but we are seeing now some serious threats to the cohesion of the whole sector of domiciliary care and care homes. I mean, Four Seasons made some very sinister comments to their shareholders just recently about their funding model not being sustainable at the present time. I mean, well, I think we're facing what could be a pretty dramatic time in that sector.
Yeah, I mean, there are lots of kind of moving parts there, aren't there? I mean, one of the things that's happening is obviously as a result of the good news, the increase in the national living wage, that's putting pressure at just the same time as local authorities have got less ability to fund people who would otherwise qualify for public support. And then you've rightly got much greater transparency and external look at the quality of care on offer inside care homes, and your favourite organisation, CQC, is obviously kind of helping with that.
Well, they'll be closed and we'll save 250 million.
So I just thought I'd like blue touch paper and see what sort of exposure we got there, but it was quite mute actually by your standards.
It was.
So yes, there are all those pressures, but there are also, I don't want to be sort of, Panglossian about it, but there are parts of the country where despite all that, actually they're doing some stuff together that really make a difference. So if you look at Oxfordshire, the Oxford Radcliffe Hospital has managed to substantially cut the number of patients who are unable to get discharge and support back home, because they themselves have sort of got more involved in the out-of-hospital community health and social care provision. If you look at Tameside in Greater Manchester, interestingly, the local authority is going to transfer over their social care staff to the Tameside Acute Trust. If you look at Plymouth, the community health services and the social care staff have gone into a joint community interest company. So there are all kinds of interesting examples.
David Dalton has hired,
Salford.
is it 300 social services employees? They've just tubed them across.
Yep. So
And
I think
does that lead us down the road to the accountable care organisation solution, do you think?
well, I think yes, you've got to kind of think about what's happening on the care delivery side, and I think some of these examples are about bringing together teams of people, but on the other side of the kind of equation is whether or not you're pooling budgets, and places like Sheffield have gone much further in pooling their budgets than is the minimum required. But it still comes down to the point that, as I've said many times, just putting together two leaky buckets from the NHS and social care doesn't produce a watertight funding solution. So actually the amount as well as the pooling does matter.
I agree. There's a fantastic book about mergers, and it's called Mergers, Management and Mayhem, and the subtitle is Two Turkeys Don't Make an Eagle. And modesty prevents me from revealing the name of the author, but it's a really good book. Let's talk about the money. I mean, it won't take long because there isn't any, is there? Now, let me get this right. So we had 2 billion from last year, we've got 8 billion from this year, 4 billion has come from DH sources. So you take that off and you're left with 4.5 billion, which the Treasury says is 10 billion. And I don't know, shit, how much money we got?
We've got more this year than we had last year. I've not got as much extra as if the economy was fizzing away we might otherwise have hoped to expect.
Yeah, never mind all that shit. I mean, what kind of mess did you get into at number 10?
What?
What kind of mess did you get into with number 10?
I don't recognise that
really?
description.
Okay. Well, I think number 10 did, didn't they? Because they were pretty cross when you unpicked the 10 billion and the 8 billion.
No, I don't think so. What I did was answer a straight question at a parliamentary committee, and of course I feel under an obligation to tell the truth, the whole truth, and nothing but the truth under those circumstances.
Yeah. Oh, yeah.
Indeed, under all circumstances. Yeah, certainly under those.
Quite right. Worth a round of applause, yeah. What a soft answer that was. Okay, right. Okay, let's. I've just got an eye on the time. Let's make the most of Simon's presence with us tonight. If you go home tonight thinking, "I wish I'd asked that question," it's your own fault. What do you want to ask him? I'll start at the back. Yes. Would you mind standing? You stand up, and you'll need big breaths, darling. Tell us who you are and your PIN number, please.
I'm a cancer specialist.
A what specialist?
Cancer specialist.
Oh yeah. Well, everything's fine with you. Sit down. Let's find something.
And I was very interested by the opening comment. According to CR UK, we're missing our cancer targets. We've been missing the low for the previous 4 to 6 months. There's no signs of an improvement in that trend. But my key issue relates to preventable cancers. Because most patients with cancer, they don't want to get cancer. But radiotherapy machines are great, the surgery's great. They don't want cancer. And the real key is to try and prevent it. And we say we've got significant improvement in our smoking, but obesity is currently our second biggest preventable cause of cancer. And children who are obese are 5 times more likely to be obese as adults.
Yes.
We had a perfect opportunity to try and address that with the childhood obesity strategy. What went wrong?
Well,
I'm really sorry. Could you just paraphrase the question because they were
Yeah.
I'll
they
give
go-
you the answer. I
yeah.
mean, basically, it was first up the waiting times targets in cancer, and then secondly, childhood obesity and obesity in general is its contribution as a risk factor to cancer. How are you going to prevent it? And the childhood obesity plan itself. Yeah. Yeah, got it.
Sit down, for God's sake.
Yeah. So it's right that on the particularly on the cancer 62-day target, there's been a huge increase in the number of people who are being referred by GPs for testing, and so although the numbers being tested within 62 days are going up, the proportions are not where we want them. So what are we going to do about that? We've got to expand the diagnostic testing capacity, and that's why one of the things I announced this afternoon was a 200 million fund over the next 2 years, precisely so that different parts of the country could do that. That in turn means we've got to deal with some of the workforce gaps that exist in various parts of the sort of provider, cancer provider services, but I think radiography, sonography and endoscopy would be three that would be sort of top of the pile. There are many others as well, but those three. And so Health Education England have got a very specific set of goals to expand supply and improve retention in those areas. And then I think we've got to also do what the Cancer Task Force asks us to do, which is to try and streamline the sort of hodgepodge of different kind of slightly confusing waiting times targets that exist for bits of the cancer pathway. And their proposition was that we should replace that with a start to finish 28-day goal. And so we've got 5 parts of the country that are now getting going, showing in practice what that would mean. And that's places like Ipswich and East Lancashire, and Bournemouth and other places to kind of really show the practicalities in terms of staffing and pathway and so on. So I think the point there is we need to expand diagnostic capacity, and if the consequence of reducing the threshold of concern, which NICE has suggested, from I think something like a 12% positive predictive value to 3%, means many more people are going to be coming forward for testing. So we've got to sort that out. But in a way, that wasn't your question. That was just your warm-up. Your actual question was then about obesity as a risk factor for cancer, and in particular childhood obesity and the childhood obesity strategy. Look, I mean, the childhood obesity strategy is produced by government. It's not produced by the NHS. What I would say about it is that for the first time, at least, it has set a quantitative goal of a 20% reduction in childhood obesity, and if it becomes apparent that we are not on track for that, then to my mind that will very clearly suggest that reinforcing measures are required over and above those that are set out in the Mark 1 of the childhood obesity strategy that they published.
Again about cancer.
Would you mind standing up?
Ozren Tosic, Pavilion Health.
Could you turn around as well so everybody can hear you?
Hello. Hi. It's about cancer, and NHS is really a center of excellence, clinical excellence. On the other hand, industry, pharmaceutical industry, and also universities are center of excellence, world center of excellence in research. And there is a feeling in cancer community that those silos are actually not communicated as effectively as they can, especially when it comes to data that NHS could provide, real-time data that are enormously important for research, and any kind of further input into clinical work, basically bringing research results and innovation into the clinic. So, what is being done?
Yeah.
Yeah.
Okay, so there were a very specific set of proposals that came out of something called the Accelerated Access Review, which was published just a few weeks ago, chaired by a guy called Hugh Taylor and John Bell, who's the Regius Professor of Medicine at Oxford. and that had some, I think, very practical suggestions as to how to kind of try and do what you rightly just described. Over and above that, as part of the conversation we're having with the life sciences industry in the run-up to Brexit, we are very keen to ensure that we kind of harness the biomedical research infrastructure in this country, the life sciences industry assets that exist, and the contribution the NHS can make. And so we've got a fairly, I think, constructive dialogue now going on. And in places like Cambridge, say, you see the kind of sweet spot where the work of Adam Brooks, the work of Cambridge University Medical School, the work of Cancer Research UK, and the big investment that AstraZeneca has made, those four partners, actually with MRC funding as well, and various others, are all coming together in a pretty coherent fashion. So I think the point you make is right, and I think people are kind of now up for, given everything else going on with the country around Brexit, are kind of willing to kind of think quite creatively about some new partnerships there.
Can I just? I'll get around the audience. Don't worry, we got time. I just wanted to talk to you about the digital exemplars. Whilst it's still in my mind, again, it looks like mental health has come out of it not as well as we might have expected, given they're supposed to have parity of parity.
No, I think what we're doing is implementing the recommendations that came out of the Bob Wachter review, and there are a set of issues in mental health services, but there are also a set of things we've got to get right in terms of electronic health records and interoperability in hospital systems. We're actually in a pretty good position as you know, as far as GP systems are concerned. So I don't think there's a contradiction between saying we've got to kind of upgrade some of the hospital systems that can make the biggest progress, with also saying that there are a set of things we need to bring to mental health. And in fact, what we're trying to do on the mental health front is get more engaged around digital mental health apps. There are a whole series of kind of possibilities there, and Keith McNeil and Will Short and Will Smart and Juliet Bauer, three kind of leadership groups.
It's very nice to see Keith back in a leading role. He came and spoke to us. He was very impressive, and we're all big fans of Keith. Okay, fine. I will get. Let's. I'm going to work my way around methodically. Let's go to Sebastian to start with. Please, can I ask you to make these brief? And if you don't, I'll just shut you up.
Sebastian, you're a paediatrician. Our STP was published today. It was trailed last week and led to a campaign by local MPs and newspapers to save our hospital.
Which hospital?
George Eliot Nuneaton.
Right.
So another campaign to save it. And I think we need a real conversation, locally, regionally and nationally, about the truth, the choices, the challenges facing us, the options. And what are your thoughts on that, given we live in this populist, post-truth world where we don't believe in experts anymore?
Can I just say, Michael Gove is my local MP. He's a complete prat.
Well, you, I guess, work at the hospital.
Yeah.
So, what's your? I mean, what's your point of view on what is being proposed then? I mean, is the code for what you're saying that you think that some of those proposed changes on maternity or children's services are right, and somehow people have got to kind of get with the programme? Is that what you're saying?
So for 20 years, there's needed to be reconfiguration across the system, and there's been a lot of struggles. And in fact, I went there to help set up a new service, and I hope this isn't going out anywhere. But it's not.
I think you're broadcasting live to the people in Nuneaton.
It's all that as intended.
Good evening, Nuneaton.
So
Nil point.
So I think that change is needed, but just this simple answer of...
Just to say, by the way, Sebastian, here is Nuneaton News.
Yes.
And the headline is "Shock Plans to Close A&E Maternity and Children's Care at Nuneaton Hospital." So that's what you're referring to, right?
That's absolutely what I'm referring to, but what comes out in the STP
How
is...
cool is that?
We're putting that in the too difficult box, so... but we need this debate, we need this conversation.
Well, hang on. Look, we keep going on. We got the House of Lords with its sustainability palaver. Health Select Committee is going to have a go. Look, NHS is sustainable if we fund it properly. End of. All the time we encourage these people to talk about sustainability, we're going to encourage them to go down the wrong routes.
There's several different things getting all kind of jumbled in together here, aren't there? The first is I agree with you about sustainability in the NHS. Let's remember that Parliament first set up its inquiry into whether the NHS was sustainable 5 years after it had been set up, when we were spending 3% of our GDP on the NHS. So actually, we periodically have these debates, but of course, that is true. But I don't think that necessarily detracts from the point that even regardless of the funding, nevertheless there are changes in clinical practice patterns, and how do we sort of sort the sheep from the goats in terms of some of those changes. There are some things where patients will just do better if you've got more concentrated centres of excellence. There are some things where the trend is in the exact opposite way, where actually, I spent Saturday evening doing a fundraiser for a new chemotherapy and dialysis unit at West Berkshire Community Hospital in Thatcham. And at the moment there, people are having to travel to the Royal Berks in Reading, or to Basingstoke, or to Oxford. The car parking is terrible at the Royal Berks in Reading, as everybody will tell you. So actually, there's no reason why that can't be much more local. So sort of figuring out what is the localising approach and what is the centralising approach, that's kind of what we've got to get right.
If the SDPs were careful about how they went about it, this is a great opportunity, I think, for, as Simon started when he said, it is local people getting together to fix the stuff that we know needs to be fixed. The trouble is, I think that they've gone at it in a rather ham-fisted way, and now we've got Jim's talking about rebooting them, isn't he, in January.
Well, no, I don't think it's rebooting. I think what we're
that's
doing
what he said.
Maybe
he just said booting.
Big ones. Yeah. No, what's happening? So let's just kind of, for those working in the NHS and kind of focus on these kind of issues, it's good just to spend a moment on this. What we're actually using our time on the next sort of month, 6 weeks, is to try and sort out, divvy up the money for next year and the year after, for 17, 18, 18, 19. And because we've got these SDPs, it means that people can kind of do so in the context of where they're actually trying to get to. So they're not just making kind of tactical decisions that are short-term smart, long-term stupid. Having done our best job at trying to make these good decisions for next year and the year after, which we're aiming to do by Christmas or just thereafter, then obviously we've got a chance to put those together with where the SDPs have got to, and then actually what we're going to do is we're going to kind of summarise those so that at the national level we can say, here's what the NHS is going to do over the next 2 or 3 years, and we're just going to be very clear about the priorities that we've got, the constraints that we're facing, and therefore in practice what we're setting ourselves as our marching orders.
I think that's very helpful, because a lot of people just see this as a bit of a muddle at the moment. Shane, let's come to you, and then I'll come to somebody else here, and then I'll work my way through. I promise I will work my way through.
Shane Tickell, I'm Chief Executive of IMS Maxims.
Our sponsors, could you give a big special round of applause? And Shane's got a bad back tonight.
If you've got any new backs going on, look ones. EPR supplier, and we're a global digital exemplar with Taunton, and we're delighted about that programme, the initiative. But my question's going to be about leadership. I had the privilege in October of spending 24 hours travelling with the marvellous Blonde, and Roy tagged along as we went around the country and visited a dozen sites of hospitals, A&E departments, dementia units, but also some social enterprise, a hostel of recovering drug addicts, and then the London ambulance service and others. And we saw some amazing initiatives. I'm a passionate believer that we all have the opportunity to be leaders and empowerment. And I wanted to ask you about your ethos and any initiatives about developing people right the way across the NHS and healthcare spectrum to stand up and do more and deliver on the STPs or whatever the initiatives are. Thank you.
Okay. Well, first up, I think that the vast majority of people, given a fair wind, will want to do the right thing. And so the question is, if we've got kind of pressures building, how do we provide the right support as against the right kind of after the event, marking up people's homework and kind of saying, well, that didn't work well, did it? And the truth is we've got probably too much effort at the moment, too many of our people on the after the event homework marking and not enough people on the sleeves rolled up, let's try and fix it. So what we've got to do is we've got to kind of rebalance where the people in different parts of the system are putting their energies. Secondly, I believe that although we're a small island, we're actually a large and diverse country, and therefore trying to make everything the same in terms of how it evolves in every part of England is bound to mean that you don't actually talk about the important stuff. What you end up talking about is the administrative superstructures and the added note paper, because that's the only thing that really can be the same as between Lewisham and Lincolnshire. So if you then get your head in the game that says we're actually going to have to let South East London kind of develop in a somewhat different fashion than the sorts of challenges that are being faced in Lincolnshire, or the sorts of answers that people are proposing in Greater Manchester, then it means you give people the space to kind of focus on what they see as are the necessary things to change. There's a caveat to that, which is that it's a national health service, and so we have to stick with the idea that there are certain sort of founding principles that we hold important to care based on what you need, not what you can pay, certain kind of key quality standards that have got to apply across the country. But by and large, not trying to kind of run the whole thing as if it was one big factory. It's not.
Right, here we go. Whoa, hang on, Harry.
The factory managers have taken the
Okay, Harry, no advertising, or I'll kill you.
Question about NHS. How are you on the GP access services? NHS, not my usual subject. 111. You mentioned that. Now, you mentioned also the admin situation. We've been doing a bit of work with the Northern Ireland out of hours service. 1.4% of those calls to out of hours get an ambulance. With NHS 111, it's 8.7%, 5 times the rate. It's interesting how the devolved nations have looked at 111 and gone, we're not going to do that. It was before your time that the Shah report predicted that ambulance calls would go up, and they have. If this was a route for the GPs, they would also, we hate NHS 111, it's a disaster. So what institutional, political, commercial pressure are making NHS England keep it going? It seems to me a disaster.
Well, we're changing it quite substantially in the way that I've just described. So at the moment, about 22% of calls to 111 are getting a clinical contact, and we are intending moving that to 30%, probably with a destination of sort of the 55% zone. That's
Northern Ireland out of hours, it's 100%.
Yeah, well, let's look at that. I don't believe on a comparable basis, and I'll tell. I mean, we can talk about this afterwards. But the cost of out of hours and 111 together for a year for your care in England, we provide you with 111 and out of hours for a whole year for the cost of less than a cinema ticket. So the problem actually is that we're probably minimising costs in that part of the system, but the consequence is far too many people are then getting referred to more expensive parts of the system. So what we've got to do is we've got to look at this in the round and say, you know what, it might make more sense to actually have more clinical engagement earlier on in this part of the process, if it means fewer people then inappropriately being sent to A&E.
We've gone full circle with this, because when it was NHS Direct, it was clinical front line. It was about £57 a call, and then Lansley flogged it off with a nominal £23 a call, and then it all became call handlers, and that was really when it fell apart.
Yeah, and NHS 111 is handling much higher volumes than NHS Direct.
Yes, I get that, but I mean, the point I was making was with the clinical front line, I think it can work, but of course as you get the volume going, it gets more and more difficult. Yes, ma'am. Would you stand up and be ever so loud?
Good evening, everyone. I think one of the best assets of the NHS is its staff. And we know at the moment staff is facing unprecedented demands, and they feel overstretched, overworked, and bullying and undermining are right across the board. Not to start mentioning what has happened to the junior contracts last year, and it's still happening. How are you tackling this?
Well, I agree with you that there is huge pressure on frontline staff and services. I think that's absolutely indisputable. It's interesting that despite that, the overall annual the annual staff survey results show that actually staff engagement with what they're doing in their local hospitals or mental health trusts has gone up. So these two things can be true at once. And then when you look at the big differences between organisations, you see that yes, there's some of this stuff that is, you know, facts about the world, and some of this is actually about the way we arrange and support staff at the local employer level. And I'm not going to kind of name names, but I mean, well, I won't name those that are at the bottom of the pile because you go look them up for yourself. But there are places, you know, I think of East London Foundation Trust, I think of Wrightington, Wigan and Lee. I mean, there's quite a lot, I think, quite a long list of places where actually they've been able to do that despite the fact that it is hugely pressurised. So part of the task is ensuring that those issues are as important as everything else people think they deal with, because there's a very strong association, as you know, between staff having a sense of pride and control over their work and the quality of care that they're able to offer.
There's Jim's talking today about the pressures being on trust, the financial pressures, and that shouldn't impact on staffing levels. The safe staffing thing that we started, I don't know what happened with it, what the hell happened. Jane took that on, and I don't know what the hell's happened to it. And Patrick is talking about benchmarking. I mean, everybody's kind of dancing around their handbags on staffing. I'm not sure there's any real clarity. I mean, it seems to me that if you're a chairman or a chief executive of a trust, you bloody well should sort your staff out and should be left to do it. But on the other hand, it's clear that when people want to save money, the first thing they reach for is 70% of their budget, which is the staffing budget.
Well, clinical staff numbers have been going up, but so has workload. So it's not that people across the NHS as a whole, we've got more frontline clinical staff now than we've ever had, but obviously the workload has risen as well. But I do think we have not necessarily been always completely smart about where we've kind of chose to see our staffing increases. I think frankly within medicine, it is unsatisfactory that the number of hospital consultants has been going up 3 times faster than the number of GPs seen over the course of the last decade. I don't think that was a smart choice for the National Health Service, and that's one of the things we've got to begin to redress.
I put health education England on the CQC, I think. All right, I don't know how the hell we're going to do this. Okay, I'll do all this side first, and then I'll do all that side, and I promise, providing we're out of here by about 11:30. Right. Please be quick.
Right, I'll be quick. Okay, Peter Tompkins, a lifelong non-executive director and governor in healthcare. I am concerned with 44 STPs. They've been put together over a 3-month period, 2-3 month period. Do you believe that all the big issues have been truly considered, both in the local clusters and in NHSI, NHSE? Have we now got the truth? Are there things that we don't know about, that you know about, that we do need to bring into the wider domain before we make plans moving forward? Because other people say there are things that we do not know about or have not yet been discussed or brought into the wider domain.
What don't we know about?
Well, I don't know. That's the bit I want to know about. I won't tell you my sources, but I know there are things that are not.
You sound like Donald Rumsfeld.
No. I think it's important.
We get the truth. We get the truth. I'm just teasing you.
Yeah. Well, these STPs are sort of developed over a sort of 6 or 9 month period, and they are what they are. The fact is that in some parts of the country, people have been kind of working together pretty well and thinking about kind of their broader challenges for some time. And so really this was just a kind of formalising of that process. In others, strange as it may seem, this was actually the first time that the same people have been in a room together kind of debating the same issues. And having had, you know, face-to-face sessions with folks twice over the course of the last 6 months as they've been kind of developing their thinking, you could kind of see that this in part was a kind of organisational development intervention as much as anything else. I mean, they won't mind me saying this, I'm sure, but for example, when we had the discussion with the folks in Kent, I mean, I don't think I'm exaggerating. There must have been more than 20 people kind of came from every different organisation, and This isn't true, but it's a flippant remark, which is that I thought to start with they were all there because they were in violent agreement, but I realised they'd all come to make sure nobody else was saying something daft. But the leader of the council was there, which was fantastic, from the county council. The leader of Medway was there, all the different trusts and so on. But I don't think there'd really been a big Kent-wide conversation prior to kicking off this process. So the long and short of it is, I'm sure that when you think about Kent, there are more things they need to work through. And I don't criticise them for the fact they haven't done it yet. It's a journey, and people started in different places and they've got to different places.
Most of the reconfigurations, I mean, over the years, if you've been around the NHS for long enough, you could almost reconfigure it itself, couldn't you, on the back of a napkin? You know exactly what needs to be done. It's just getting buy-in locally. Right, yes, sir, can you be very brief, please, with your question?
My name is Robert Elkeles. I'm a retired consultant at Imperial College and board member at Infield CCG.
We know what you see there, we want your question.
We know that the vast majority of NHS provider trusts are in serious financial trouble. Would you accept that it is not due to bad management?
The last time I met you, sir, I think was here, and I think I detected a familiar resemblance with your son, who is the chief exec of a hospital trust. So are you asking on his behalf?
No.
Well, then the question is, why not?
Everybody, it's Daniel Elkeles, and he's the trust chief exec down at Epsom and St Helier, and obviously his dad's worried about Daniel's financial position. So it's nice of him to send
Jolly
Pop
fine
along.
trust, but they got no money.
Okay, point noted. Thank you, Daniel.
Okay, fine. Who's next? Who am I coming on this side? So I did side. Mr. Klein.
Simon,
Would you mind standing up? Are you still able at this late stage
of life? So you're the first chief exec to come in to the NHS talking about equality rather than raise it as you go out. I think you've made a bit of progress in the last couple of years. So my question is, how do you think we're going to make that sustainable after the initial push is over?
And of course, the person who really knows the answer to that is Roger. But I will give it my best shot. Yeah.
Read my report called Snowy White Peaks.
Yeah. Well, no. I mean, it's all seriousness. Roger done the NHS and the country a huge favour with his colleagues in actually holding a mirror up and just kind of. It was a great report. It was a great report, and just proved beyond all doubt that it was appalling and unacceptable situation. So, I mean, I think, Roger, as we discussed and you know, there are some things that if we get critical mass, I think it won't reverse itself. And this is true of lots of elements of social change, actually. I don't think this country is, I mean, if I can use a different example, I think we've come on an enormous distance on marriage equality in this country over 10 or 20 years, and I don't think that's ever going to be put back. On the other hand, there are some things where you think you've kind of made an advance and then actually it erodes, and I think we've had that experience in the NHS sometimes around workforce race equality. There have been times when actually people have really kind of had a focus and got it, and then we've kind of stepped back. I think we have stepped back since, frankly, the late 90s, early 2000s around representation on trust boards and, by extension, CCGs as well. So I think we're making some progress now on board level director representation. I think the journey we're on around the workforce race equality standard feedback to individual trusts and, first of all, very gently just kind of showing people, did you realise this is kind of the different experiences that staff in your own organisation are having, and then sort of gradually ramping up the volume on that over the course of the next couple of years. I think that's going to be the difference. That will ultimately be the test as to whether we have or haven't kind of made this irreversible, when we've got a steady stream of senior people, both from black and minority ethnic and other backgrounds at all levels in the NHS, including chief execs, including not just non-execs on the NHS England board, but national directors at NHS England, and the same be true for other national ALBs as well. So I think we've begun a journey, but we are by no means there.
Okay, I'm still working my way back. Yes. James, thank you.
Just a finance question. Are the STPs the death knell of the internal market, and therefore is payment by results next?
What was the question? Say it again.
Are the STPs the death knell of the internal market?
Well, let's hope so.
And is PBR next?
Well, I hope in many respects PBR is next. Yes, because I think if you think about the sort of mix of financial incentives and organisational autonomy and the sort of regulatory regime that we set up in the early 2000s, it was to try and solve a particular problem for patients in this country. And the problem was that people, the number one thing that people were pissed off about was waiting too long for having an operation. And everybody remembers you were waiting 18 months, 2 years to have your hip, your knee, your cataract. People were waiting more than 6 months for their cardiac surgery. 500 people a year were dying while waiting on the cardiac surgery waiting list. And so the question was, how do you put extra money into the NHS and make sure that in a capacity-constrained system, as it then was in the early 2000s, we buy extra services rather than just frittering it away in inflation? And so you need a set of incentives, of which payment by results, payment by activity is one, to ensure we do that. And you know what? The NHS did brilliantly well. It demonstrated that if you put the money into the NHS, you will get results out. And so we saw waiting times fall from 18 months to 18 weeks. The median wait for an operation is 10 weeks. We saw a doubling of public satisfaction with the National Health Service, and we saw big improvements on major killers as well: cancer, heart disease, others covered by the so-called National Service frameworks. However, that's not now the situation we face. That's not now the problem set that is kind of principally in front of us. The problem in front of us now is not how do we spend another couple of percentage points of GDP and wonderful growth and get good value from it. The question is, at a time of huge financial constraint, how do we make sure that we are more than the sum of our parts, that we're dealing with the kind of inefficiencies that are often at the handoff between organisations, that we recognise that it's long-term chronic health conditions that are the principal set of things we've got to get right, and that there are other bits that we've neglected, be it primary care and general practice or mental health services, that are not on a click of the turnstile payment method, that we've got to get sorted. So for all of those reasons, I don't think that the policy mix we had in the early 2000s is the policy mix we need now. I do not believe, however, that new acts of parliament are a cost-free way of moving from where we've been to where we need to be. And so, in effect, what we're trying to do, as I've sort of said before, is if we collectively act as if the system makes sense, then we stand a greater chance that it will.
I think it's a great answer. Yes, sir, right at the back.
Yeah, my name's John McDonald, and I'm a consultant psychiatrist, so greetings from St George's Hospital in Scotland.
Ah, right, yes, hi. Yes, yes, indeed. Is that where you work?
Yes,
Europe, yeah.
other places. I'm also a Chief Clinical Information Officer. We're trying to do something with digital.
Right.
Simple question. Other organisations which have transformed using digital technology, the first step is to collect the patient's email address and give them a username and a password. Currently, my spend on set class stamps, not dictating, not consults time dictating, not typing, just set class stamps, is £750,000 a year, every year.
Wow.
It's money wasted every year. Can I please email the patient?
Well, I mean, it sounds sensible to me, but let's talk afterwards and reconnect on old times.
Yeah, I'll give you a strong maybe. Neil, but can it be very brief, please?
Okay, the money question. I'm a baby boomer. Quite a lot of people here in the room are baby boomers. In the 80s, Mrs. Thatcher took away our interest tax and used it to spend on public services. In the 90s, Ken Clarke did full fuel escalators and lots of other cunning plans and took money off the middle classes. In the 90s, Charles Clarke brought in tuition fees and made middle classes pay anything up to 40, 45,000 for the education of their kids. These were huge redistributions. The NHS and the government stumbled over Dilbert to make the baby boomers pay, and the middle class baby boomers pay their share. As the chief exec of the NUS, do you regret or resent the fact that you have not had the largesse that has been given to university vice chancellors and the transfer of money that ought to happen between the generations through some mechanism like Dilbert? Perfect. Oh, you may not be able to answer that question.
That's quite a profound question.
Well, I think we're right to the honourable member of your answer.
No, I think it's a very interesting line of argument. I think two things about the social care element of this, given you're talking about DIL not, and as I understand it, the government is not, the government's position is still that they intend to do DIL not in 2020. I think that's their continues to be their stated position, be that as it may. First of all, I think there are some tactical things that can be done around social care funding now that don't require you to kind of reimagine Beveridge or the welfare state. But secondly, I do think there is a debate to be had post-2020 about what is the sort of retirement deal that we offer to keep people not just keep older people not just in income security, but also housing security and care security. And I think it was interesting that the Chancellor in the autumn statement said that they intended to take a hard look at the triple lock post-2020, which, depending on how they think about that, might give more flexibility in this space. And I think I'll leave it there.
Right, I'm going to move from the back, yes. Weenus.
Hi, my name's Nick from We Communities. I'm wearing two hats, so I might squeeze in two questions, but both very
I doubt you will.
You are clearly very passionate about the NHS, the patients, the workforce. I have in my hand about 200,000 very passionate healthcare workers on Twitter. Is there any chance you could join us sometime soon? Because your access to your knowledge and support for them would be fantastic. So that's the first question. The other question is, I am over 40, I'm becoming less overweight by the day, but I can't do anything about the fact that I'm probably going to key away with genetic heart condition. I know this, my GP doesn't know this, A&E doesn't know this. When are we going to unlock our data and get really preventative? The NHS use of data policy says that you cannot look at my data until I present myself to a service. We're going to get preventative and we're going to get smart and we're going to get efficient. How are we going to start using this data to find the people that need help before they know it?
Well,
we've got an expert on data sitting here as well, right in the front.
Yeah, what's the answer? You're drawing a blank down there. No, I mean, I'd love to chat actually about the last of your points there. I don't know what the answer is, but I think you make an important point. Obviously, Fiona Caldicott's been looking at these kind of issues, and the Department of Health is due to kind of set out the stall on this. It was, I thought, notable that the Information Commissioner within the last few days has sided with NHS Digital in terms of the approach that NHS Digital are taking to making anonymised data available for researchers. Obviously what you're talking about is something different, which is personalised data that would be available. I don't understand off the top of my head why, if you consent, those kind of data shouldn't be available on an expanded version of the summary care record, and that it wouldn't feed into kind of more proactive support for you ahead of your ending up in an A&E department or your GP surgery. But I think that this is a coming conversation. I think it'll be really important, by the way, that voices like yours are helping inform the public debate on this, so that it doesn't just become a question about respecting people's rights to confidentiality, which obviously is entirely appropriate, but you also...
But it is being done. If you look at Healthy Liverpool, for example, we went up and saw it, and right across Liverpool, they made all the records available right across. Now, I have to tell you, it was a gargantuan job. It involved 3,000 consent documents, which was, horrendous. But they've done it, and it is being modelled, I think, on the Wirral. Is that right?
Yeah, that's right. So Gary Price from the Wirral, we're a global digital exemplar.
Can you stand up?
We've got a population health system that links primary care, secondary care, community care. All the information comes in a cloud model, and now we've got access to all that information. That was 300,000 population, and we had to introduce an opt-out rather than opt-in. We got a few thousand opted out, we got the vast majority.
It is an absolutely, it's a dog's job to have to do. I should explain, Gary's been shadowing me for the day, that's why he's here tonight, and he's just thinking, what in God's name did he let himself in for? Right, where are we going? A lady here with the black...
We missed the Twitter answer, Simon.
Yes, I think that was deliberate. Right, I'll save him.
Hello, Sarah Wilton.
Oh, you're Sarah Wilton. Yeah. We've been waiting to hear from you, Sarah.
I'm sure everyone in this room is absolutely committed in their hearts to free NHS care delivered at the point of need. But in our heads, we're starting to increasingly realise that that's just not going to be possible, however hard we try, however many STPs we deliver. Isn't it really time that we started to bite the bullet, the silver bullet, challenge bravely, intelligently, and look at the best practice in Europe and start to introduce something that enables a bit more contribution, whether it's an insurance system or whatever? We just don't seem to even look at it, discuss it in this country, and I think that we've clearly not got enough funding, and that's surely an answer. I don't understand why we're not looking at it.
How would you do it then?
Well, I'd look around Europe at best practice in France, and there are insurance schemes in France that some people who can afford it pay a very small amount as part of their employment taxes, and 10%, 20% of the health budget.
What is their GDP? What percentage of GDP?
I think they spend more than we do.
Well, there you are. There's your answer.
Well,
isn't it?
Yeah, I mean, I think for a start, I think I'd challenge the premise of your question. I'm not sure that the heads, let alone the hearts of the British people are where you think the heads of the British people are. And I think one way of answering the question is to see what their elected representatives kind of infer to be the views of the British people. And so I thought it was quite revealing that although during this highly contested referendum debate, the NHS wasn't on the ballot paper, but it was on the side of the battle bus. So if you're kind of making big pitches to the British people about a well-funded NHS, that tells me that actually the calculations that a lot of people are making is a bit different than the one you're making. But even putting that to one side, the reality is that Germany decided on its health financing system in 1883. Bismarck was the first politician to think that having the state in some way involved in shaping healthcare financing would be kind of good for politicians. And in 1911, Lloyd George copied that, for GPs at least. And then in 1946, we decided to go a different way. There are very few examples of countries having kind of, through accident of history, chosen a particular funding model, then choosing to kind of switch. And the idea that at a time when we are going through the Brexit process, we're dealing with all of the pressures on our employers, businesses, labour costs and so on, the idea that we would sort of load another 8 to 10% of GDP onto the cost of employing people through the workforce, I think is implausible.
And I think it's worth pointing out that we're putting 6.3% of GDP into healthcare at the moment, and it was 6.3% back in the year 2000. There is just not enough money in the system. Now that's a political choice. There's an election coming, and you know what we've got to do. But we've got to kick the bastards out.
And at this point, I mean, it's sort of a Trumpian style. Lilley announces his candidacy for Prime Minister of the United Kingdom.
Yes, sir. With his gentleman with his hand up there. Yes, I'm working my way forward, and I'll come to Michael last.
Andrew Gardner. I mean, it's very much on the theme of some of the other questions. We've been looking at the demand on primary care, and one interesting fact.
Who's we?
Maybe we look at digital front end, and 10% of the patients drive 50% of the appointments into primary care. We want to do two things. We want to have a digital front end that gets access into the GP record, and we think you need apps which can change behaviour, because a lot of those 10% have a BMI higher than anybody else that have diabetes. They need behavioural change, not medicine. What are we doing to make sure that EMIS and TPD open up their information for digital to take off? And are we going to get NICE to allow us to prescribe wellness apps like that? Because like Jennifer said back at the beginning, unless we do prevention, we will still have a massive demand on the system.
Yeah, I don't think we necessarily need NICE to kind of give that the go-ahead, but your point is a good one. We are actually over the course of the next 6 months going to be, a number of GP groups have or either developed their own or are working with third parties around the kind of approach to digital front end that you described. And so we are over the next 6 months going to be supporting some parts of the country where they're using homegrown versions, and some parts of the country where they're using third-party solutions. So it sounds like you should be talking to some of the folks who are working on that and see whether that's something that can be tried.
In the States yesterday, they announced a more rigorous examination of health apps, and I think we're probably likely to see something like that happening here, because there is a lot of stuff on the market that really probably shouldn't be there, if you're really going to trust it with your health. But I agree with you. I mean, if you look at organisations like EMIS and so on, they're proprietary brands. They don't have to open their back end if they don't want to, unless we do something about interoperability, and that's within our gift. I mean, we could be much tougher, I think, on interoperability. At the moment, we just palaver about and say, would you all talk nicely together? I would say we won't buy stuff that isn't interoperable, and that's it. And that's probably killed our sponsorship for next year. Right. Yes, sir, gentleman here.
Stuart Jackson, passionate about people leadership. You're stuck in a lift while you're travelling. If you've got about 60 seconds, thinking about our next generation of healthcare practitioners, doctors, nurses, anyone, what would be your message to them if they were thinking about a career as the leader of the NHS?
If they were thinking about a career in medicine and healthcare, or in...
As management, you were talking about? Or
Anything
in the NHS?
Anything. Nurses, Zocky Health, what would be your message?
Well, if the question is why would you want to come be a health professional in the NHS, I think the answer is because these are jobs that are highly worthwhile, in that you're doing something hugely important for patients and for communities. They are intellectually stimulating, they involve lots of teamwork, and they give you enormous flexibility over the course of your career, over where you'll be working and what you'll be doing. Step on down.
But it's a good answer. It's interesting that the Secretary of State was talking the other day, wasn't he, about more clinicians in management, and he got himself into a bit of a tangle with the Health Service Journal over that, or the Health Service Journal got themselves into a bit of a tangle over that, I should say. I mean, there's a strong sense of vocation in becoming a clinician, isn't there? It's often runs in the family and all that kind of thing. To come in as a manager into the NHS, I'm not saying there isn't a strong sense of vocation, because there is, but it is increasingly difficult to attract people to the top line jobs. 20%, I think it is, of top jobs as managers in the NHS are now vacant or have an interim. It is becoming tougher and tougher to hold down the big jobs, and it's getting tougher and tougher to get people to do it.
Yeah, these are tough jobs. I think there's a few kind of other sort of facts that would be worth just kind of inserting into the conversation on this point. First is that, of course, the majority of management done in the NHS is already being done by clinicians.
Yes.
So most partners leading GP practices are GPs, or they might be practice managers, nurses, but by and large GPs. In hospitals, most of the management, with a little m, is actually being done by ward sisters and charge nurses, together with heads of physio, therapy departments, scientists and so on. And in terms of the medical disciplines, most hospitals have a clinical directorate system that has a doctor or a senior clinician as the clinical director. So really this debate has been a debate about chief executives, and the truth is we need both, and we need kind of to give ourselves the best of both. And in NHS England, I mean, I've employed a guy called Jonathan Fielden, who was the medical director of University College Hospital, as our director of specialised services, fantastic clinician, Eustace, former chairman of the BMA Consultants Committee, I like that. We have employed Arvin Madden, run our GP services, but I've also employed Callie Palmer, Chief Exec of the Royal Marsden, to be our National Cancer Director, and Claire Murdoch, a former nurse, to be our National Mental Health Director. So I think, we're a team with 1.3 million people, we've got brilliant talent to choose from. And the other point I would just make, Roy, is that despite all of the talk about kind of, the pressures and the challenges on management roles, the NHS Graduate Management Training Scheme is one of the highest regarded and most oversubscribed by the best and the brightest graduates, beating the applications you get for many others, be it, in some years, more than the BBC and Goldman Sachs and Procter & Gamble and British Airways and the Civil Service and Uncle Tom Cobley and all. So actually bright, committed young people want to come and work in the NHS, and they want to come and work in NHS management.
They do. And I was speaking to the management trainees at Guy's just recently, and it was interesting. I went round the table and asked them why, given all the crap there is in the NHS, why they wanted to do it. And they said, well, because there's crap in the NHS. They were kind of inspired by the challenge.
I joined the NHS in 1988 in the management training scheme, and it wasn't all going swimmingly in 1988 either. I can tell you.
I joined in 1974, and I can't remember a time when it ever went swimmingly. Where are we going? Yes, ma'am. Yes.
I'm Catherine Holford, the Chief Nurse at BHRUT.
We're in the presence of greatness here. Mind what you say.
I, like a number of Chief Nurses, struggle to recruit people, so they spend a lot of money on bank and agency. In April, I went to the Philippines and recruited 155 Filipino nurses who should have been here by October to help me with my agency spend and to ensure that patients get the right care. To date, I've got 4. They're completely blocked coming into the country for a number of reasons, and I just wonder if there's anything that can be done to help us get these nurses, to help us look after patients in a more consistent fashion.
Yeah, well, we should certainly look at. I mean, I think it's often a combination of visas and NMC registration, isn't it? And I know that the NMC have been looking at how they streamline their processes internationally as well as domestically. But I'm sure Ruth May at NHSI would be very keen to work with you on what that looks like.
I think we've got to be realistic about Brexit and what it means to the NHS. Myself, I mean, I was with some Portuguese nurses recently who were saying they were going home because they weren't certain whether they could stay, because they realised they were going to be used as bargaining chips in keeping grannies on the Costa del Sol. I mean, we just got to accept the fact, understand the environment within which our business activity is taking place, and it's, I don't expect Simon to agree with this or not, but I mean, it's Brexit that's screwing this whole thing up, because if you look at the net migration figures that were announced last week, it's going completely in the wrong direction for the government's point of view. And if you really think they're going to start shipping in loads of nurses from overseas, I think you've got another thing coming. We've got to be more creative in our solutions, because I don't think that we're going to be in the present political climate. I don't think it's going to be easy to depend on bringing in nurses from overseas.